I was born in Washington, D.C., and I went to George Washington University Med School. And then after that, actually the Army paid for my med school, so I had to pay them back. So I ended up going to Beaumont Army Medical Center in El Paso. I did my internal medicine training there. And then after that, I did Desert Storm for a year with my wife. That's where I actually met my wife right before then, and we did the Desert Storm experience together. It was a bonding experience for both of us. That's just a joke, but anyways, turned out okay. That turned out okay. And then we came back, and I did a pulmonary and critical care fellowship at Brooke Army Medical Center, which is in San Antonio. They have a big burn center there, and that's sort of the second leading Army medical center after Walter Reed. And then when I finished up at Brooke, I went to Scripps Clinic to do a year of sleep medicine, and that's in San Diego. That's a nice place. And then I came back and did my payback at Walter Reed Army Medical Center, which is in Washington, D.C., and that's now merged with the National Naval Medical Center, and now it's all the big, Walter Reed Medical Center in Bethesda, Maryland. So that's my background. After that, I was in Seattle for 6 years. It's also in Oregon, and then I've been here in California for the past 5 years. My wife was born in San Francisco and such, so we've always wanted to come back to California. Now we've been here 5 years, and we love it here. I mean, my kids love it here. I've got 2 boys, and they're both college age and doing the college thing. But we love NorCal just like you guys do, and we're happy to be here. Now, when you guys come to clinic, whoever ends up in clinic, I hope you don't end up in my clinic. I hope you don't need me. But if you do, I want to hear about you guys too. I mean, I want to hear about you. I want to hear about your kids. I want to hear about your life. I want to hear about what you want to accomplish, how I can help. Those things are really, really important, because it's not, it's all these doctor things and hospital things are all just built on the framework of what you want to accomplish and what you're going to do. So a lot of times these doctors come up with all these plans and nurses and all that, but if people don't want to do it, it's not going to happen. So I always want to hear from patients immediately, that's ridiculous. What are you talking about? I'm not going to do that, because then I know, and then we won't do it. We'll do something else. So the main thing, even here in the hospital, is to do what people want, because it's not going to work otherwise. It's just, that's how we are. We're people. So that's the main thing. And you can, tonight too, when we talk about things, when we do a question and answer after, I just want to, it's always good just to put it out there, and because otherwise, you end up telling the truth anyways eventually. So it's always good to hear it ahead of time, so you know where everybody's coming from. So that's kind of where I'm at. So that's my background, and I want to hear your guys' point of view on things too. Okay, so breathing easier, living better, Adventist, the whole philosophy about holistic living and holistic healing. That's what this is all about, and I'm just a very small part of that, the service that I offer. There's 3 components to what I do. The first component is being a lung doctor in a clinic, which is across the street. The clinic's across the street. And 3 days a week I'm in the clinic, and most of the day, and I just see you. You guys come and visit, and I see you and take care of you, and we talk about whatever problems you have. The nice thing about the clinic is that people are not so sick. And if you don't get it right the first week or the first month, there's time to get it right. It's not like being in the hospital. Now, sometimes people do, it's a little bit more urgent, and if that's the case, then we'll send you to the ER, we'll put you in the hospital, that kind of thing. But the clinic is a much lower key place where we just gradually work on things to get better. That's the clinic. The hospital is a different story. The hospital is where we get things done for you. If you end up in the hospital and I'm working with you, I want to get things done. I don't want you to sit there. I want to get things done so that you don't have to come back to the hospital. You can be in the hospital for as few days as you need to be, and then get you home again healthy. And I do critical care. So here in Ukiah, I work in the clinic for you, but when I'm not here, I'm doing critical care in other big hospitals, and that's very much different. It's very much different. So here, when I visit with you, you'll remember me and we'll talk and all that. In the intensive care, it's almost better not to remember your doctor. The best doctors, I think, in intensive care are the ones who save you and get you better, and you don't remember, and then that's great. So it's a whole different kind of thing in the intensive care unit. So we have an intensive care unit here in Ukiah. It's small, but the doctors that work in the hospital are terrific. We have hospitalists in the hospital that are always here, and we have emergency department doctors that are always here, and we have general surgeons that are on call always. So you have those three sets of people here in the hospital all the time that can pretty much stabilize anything. And I'm always available by telephone. So that's a whole, that's an added layer for them to get another opinion about what's happening. And you know, the notion with Ukiah is, even though it's a smaller place, it's a pretty busy place. It truly is. It's a pretty busy place. And they do a really, really good job here. You know, I'm coming in as a person that's only been here for 6 months now, 4 to 6 months, but I've never been associated with a smaller place where they do such a good job. It's amazing here. Most smaller hospitals are contracting. They really are. They're not able to stay afloat. And Ukiah is vibrant and growing and probably could grow as big as it wants to grow. So it's really a different situation here. And I think you all are very, very lucky that you're in this community, because Gwen Matthews, who's the CEO, and a lot of the people here have a vision for the community. They truly do, and they want you to be a part of it. And all the nurses and the respiratory therapists and the doctors have all bought into it, and they've been, you know, it's just a continuation of what's always been the case here, is that people work together really well, and they work for the patient. So, and what I was telling my wife last night, I went to a respiratory therapy meeting yesterday, and there was no hierarchy at the respiratory therapy meeting. A lot of times there's all these hierarchies in different companies that you work with. The kind of company you really want to, the best companies are ones where there aren't hierarchies, where people can just speak their mind. If they don't agree, they speak their mind. And then what they're thinking is sort of integrated into what the actions are of the group. So that's what happens at Ukiah. So if somebody's concerned about something, or they have opinions, they speak their mind, and then that gets factored into things. And that's the case with you guys. Your opinion is, and how you're feeling and how you're doing is the primary issue. But then all these other people are also inputting on what's happening with you. So blah, blah, blah. That's a lot of talk, but it's true. It's true. Now we also have sleep medicine, and we have a new thing where we do home sleep studies versus having to sleep in a sleep lab. And that's nice. And it's mainly to look for obstructive sleep apnea, which is lack of breathing during sleep. So that's something new. And if you need evaluation in that way, we have that now. The lungs are interesting organs. You have to have it. And once your lung function starts going down, it's tough. I mean, it's a terrible sensation not to be able to breathe well. And I hope none of you have to ever experience that. But there's a main breathing tube called a trachea. And then the trachea divides into the two large bronchi, a right and a left. And then here's the lung tissue on each side. There's a right and left lung. And it's interesting that both lungs are separated. There's two lung cavities, and they're completely separate. So you could get shot or have stabbed, and hopefully that will never happen to you, but that can happen on one side. Something happens on one side, and then the other side is just fine for a while. But so the good Lord gave us two lungs so that we can get by on one lung if we have to, and that's true. So if your underlying lung function's good and you lose a lung, you can still get by. Now, when we look into the lung tissue with a scope, let's say we take a scope and we go down through the mouth and nose into the lungs, we can only go out so far with the tube. When I look into the lungs, I take a scope and go look down in there. It's called a bronchoscope, because the lung tubes start to split and get smaller, and then you can't look too far out. So we have this bronchoscopy. We look into the lungs, but we can't see beyond a certain distance into the lung tissue. So there's a lot of lung tissue we can't see. That's why we have to use CAT scans and all that to look at the lungs. At the end of the lung tubes are these air sacs, these balloons where their oxygen exchange occurs, and they're called alveoli. And the alveoli are just balloons. They really are. And they're bathed in blood, in capillaries, and the blue blood is blood without oxygen, and the red blood is blood with oxygen going back to the heart. And the alveoli is where all the action occurs, where all the gas exchange occurs, so your body can get rid of carbon dioxide, waste gas, and then pick up the good air, the oxygen, and bring it back to the heart, and the heart pumps it out to the rest of the body. When the lung tissue is destroyed, oftentimes the alveoli either get flooded with inflammation or in other ways get destroyed, and that's when we get into problems, because all of a sudden we don't get that good oxygen that we need, and we can't get rid of carbon dioxide. And if anybody has questions, just raise your hand. And yes, ma'am.
How would they get destroyed?
Many, many, many ways. One of them is COPD. So a person smokes. They smoke more than a pack a day for 35 years. Typically, the lungs will start to be destroyed. So COPD is emphysema, and that is irreversible usually. But once people stop smoking, the lung damage stops. So that's one mechanism. Another mechanism for the alveoli to be damaged would be pneumonia. So you get all this bacteria and pus in the alveoli, and that's pneumonia. Okay, so I mean, pretty much this is it. How do you? I mean, the alveoli are the big players, and if the air doesn't get into the alveoli, we have trouble. So COPD, destroy the alveoli. Asthma is different than COPD. They're very, very different. People, typically there's no COPD without smoking most of the time. Asthma is a different thing. It's a whole different process. It has to do with the airways closing up so that people can't, the larger airways, so people can't get the air out. I don't know if you've ever had that experience where you get exposed to something you're allergic to, and you have, I don't know, anybody have asthma? Anybody ever experienced that? Terrible feeling not to be able to get out the air, but that's what happens. And there's a number of different medicines that can be used to open up the airways. Lung cancer is a big issue. It's a big issue for you guys. If you came of age in the 40s and 50s and 60s and smoked and then stopped smoking in the 70s and 80s, and now you're 60 or 70 years old or 80, really the risk of lung cancer is there. So we're seeing the post-war folks coming through with a lot of exposure to tobacco, and then a lot of lung cancer that's occurring. Now, there is some lung cancer that's not related to tobacco, but a lot of it obviously is related to tobacco. So what Adventist has come up with is a screening program for lung cancer, and I'll talk to you a little bit about that in a few moments. Pulmonary fibrosis is a fancy word for scarring of the lung tissue, and that can occur from many processes. It's usually, by the time people have fibrosis, which is extensive scarring, it's usually irreversible. So hopefully none of you have that. And if you do, hopefully whatever process caused that inflammation and scarring has stopped so that your lung function is stabilized. But lung doctors have a real problem with pulmonary fibrosis because it's very, very hard to treat outside of a lung transplant. And there are not that many lung transplants being done, unfortunately. Bronchiectasis is something that we see a lot of in clinic. I don't know if any of you have that, but bronchiectasis is a opening up of the airway tubes, of the bronchi, of the smaller airway tubes, due to prior lung damage from prior pneumonia or bronchitis or tuberculosis when people were growing up in the 30s or 40s and 50s and didn't get antibiotics or didn't get treatment for TB. So these airways are damaged, and then what happens is now that you're older, 60 or 70 or so, bacteria and other type of infections get in those airways, and it's very, very hard to get rid of that. So I have a lot of that. Your primary care doctors may not have heard much about that, but I see a lot of it in the clinic. It's a real tough thing to treat, real tough thing. Occupational lung disease, this is very, very important to us here in NorCal, especially in Ukiah. A lot of agriculture here. Meat cutters, fishmongers, farmers, food processors, people that work in the vineyards, any kind of exposure to cut materials, proteins, can cause, it's fancy, there's a lot of fancy names for it, but just a lot of inflammation in the lungs. if it's treated early, it's reversible, very treatable. So wearing a mask is key, and avoidance is key, and then people can be treated with steroids and all kinds of things, but obviously avoidance is the best way, because if you continue to be exposed, eventually all this inflammation turns into fibrosis. So yeah. Do you know anybody with occupational lung disease? Do you know anybody? Can't say? Can't say? Okay. Pulmonary hypertension is increased blood pressure inside the lungs. Pulmonary hypertension, increased blood pressure inside the lungs, and that can be caused by many things. And that is something that needs to be treated and requires specialized treatment. And there's a lot of medicines for that. The treatment's very expensive, but if you don't treat, people don't do well. So people that have taken, women that have taken diet pills over the past 10 or 20 years, people with various other underlying medical problems, they can get this increased blood pressure inside the chest, inside the lungs. Sleep apnea is lack of breathing during sleep. It's probably overall about a third of the population has lack of breathing during sleep. That's moderate to severe. It's a function of age. As you get older, your throat gets floppier and collapses when a person is sleeping, and that's treatable, and we'll talk about that. And then pulmonary emboli, I mean, these are all things that, I don't know if you've heard about these, but these are things that get us. Pulmonary emboli is when blood clots go from the legs into the lungs. The lungs act as a filter to catch these blood clots, and that's one of the things that tends to kill us as we get older. So a real big problem. So ways to help your breathing, I mean, they're really, really common sense things, but they're easier said than done, truly. If anybody who's ever smoked knows how hard it is to stop smoking. Once people taste cigarettes, I smoked a little bit in med school, and every time I walk by somebody smoking a cigarette, I'm like, that smells good. But I know I can never smoke because I don't want to get heart attack. I don't have a heart attack or stroke, and I don't want to develop emphysema. You really only have to smoke a cigarette or so a day, and then all of a sudden your platelets get activated and people get a markedly increased risk for heart disease. To stop smoking is easier said than done. I don't pass judgment on people that still smoke, but I encourage them to stop smoking. Anything I can do to help. We have smoking cessation programs here that the hospital sponsors. I doubt that a big-time smokers would show up at the pulmonologist, dessert seminar, but I mean, there's no judgment. We're not passing judgment. We're not passing judgment, and anything you can do to decrease the amount of cigarettes that you smoke is helpful. And nicotine patches, it's always worth another try with that. The e-cigarettes, there's a lot of controversy right now about the e-cigarettes. It still has the bad effects of nicotine, but at least you're not inhaling air. There's an e-cigarette, so that's a start. A lot of controversy, but no judgment, and anything that we can do to help. One main issue with people that continue to smoke is to screen for lung cancer, and Lord forbid if the lung cancer comes up, to get rid of it as soon as possible, to recognize it and treat it so that people can live as long as possible. When you're spraying your rose bushes with anti-deer spray, or when you're doing whatever crazy stuff you spray in your yard, or sanding doing carpentry and sanding, or whatever things that we all do, really wear a mask. Really, really. I tell my wife, I'm like, I've seen people who've trashed their lungs with deer spray. Crazy things. You don't know if you're going to have a reaction to it or not, but I've seen all kinds of things where people damage their lungs. So I'm always trying to get my wife to wear a mask if she's spraying any sprays. I try to stay away from that. If you're spraying your fruit trees with pesticides, all that stuff, wear a mask. Wear a mask. Don't mess with it. Just be careful. Same kind of thing. Soldering, welding, all that kind of stuff. You got to be really, really careful. Sandblasting in your basement, all that kind. Does anybody sandblast in their basement? Hopefully not. I always ask people if they do that, but there are some people that do that. There's like artists that do that, and then people that polish up gems and stones and such. So, use that common sense. Get a good mask and wear it. For people that are here, a lot of you that have underlying lung problems and you're here because you're interested, if you get a cold and it doesn't go away within 1 or 2 days, your primary care doctor needs to treat you with antibiotics because your lungs are already weak. You're different, you're special. You know, you're not like your 17-year-old grandkid who's gonna, the bronchitis is gonna go away no matter what happens. The folks that I see in clinic, they need to have antibiotics as soon as possible when they develop respiratory infections. So if you're...
At what age are you not one of your grandchildren?
Oh, I think 75 years old would probably be the cutoff. No. So what age?
40-year-old father is all right if he gets bronchitis.
Depends on the guy, depends on the patient. So if he doesn't have any underlying lung disease, then he's okay to wait. But people that have underlying lung disease or other reasons should be treated early. So that's different than what your primary care doc is oftentimes sees a lot of healthy patients. So they're not going to want to give antibiotics, but the patients that come into pulmonary clinic typically need antibiotics quickly if they're not getting better from respiratory infections. So that's different than the general population. Okay, lung cancer is the #1 cancer killer in the United States right now. It has, there's no nerves inside your lungs. When we do a scope test and I look down in the lungs, the only place it's uncomfortable is in the nose and the back of the throat because there are no nerves inside the chest. There are nerves on the chest wall and on the outside of the lung, but there are no nerves inside the lungs, truly. So you're not going to feel anything until it's too late. If, Lord forbid, you get lung cancer, you're not going to feel anything until it's too late. It's awful. So that's why the American Thoracic Society, the American Cancer Society, American Lung Association, all these different groups, they want people to have screening for lung cancer. So again, more than 35 pack-year history of smoking, which is more than a pack a day for 35 years or equivalent, and haven't stopped smoking. It's been longer than 15 years. We recommend a screening CAT scan. And they're starting to do low-dose CAT scans here at Ukiah Valley Medical Center. So that's something that if you come to see me, I'm going to do it. And then if a lot of us are going to have little nodules just because we do. It's not cancer. You have to track those and make sure they're not cancer. So, and we do that. We do a lot of that. The hospital wants us to do that because that's what we should be doing. So that's part of the reason they recruited me was for lung cancer, part of a lung cancer screening program here to set that up, help with that.
Did you look at this and people haven't smoked?
Lung cancer screening for people that haven't smoked?
What about getting lung cancer without never smoked?
It happens. It happens. It's you have to be unlucky, or just have but it happens. It happens. It's unfortunate. You hate to see it. People get cancer that spreads from other parts of the body into the lungs, and that's a different situation. But that happens, and we do everything we can to treat that. Okay, so lung cancer screening is an Adventist priority. Anything we can to detect cancer early, because if cancer is detected early, it can be treated, and people's life expectancy and quality of life is greatly increased. So it's a real big deal. It's a real big deal. So I keep talking about bronchoscopy, and bronchoscopy is a lighted tube that goes down through the nose or the mouth into the lungs. And it's done here. We do it in the operating room. There's an anesthesiologist that will put people to sleep. We don't put a tube down their throats. It's not like a surgery or anything, but people are asleep and they're relaxed. Has everybody here had a colonoscopy? No. Yeah, colonoscopy? That's not very much fun, is it? No. That's terrible. I don't know how those guys do that kind of thing, those GI doctors, but don't tell them I said that. But bronchoscopies, the scope is really, really small. It's about half the size of this finger here with respect to the diameter. So it's like a piece of macaroni that's flexible, and you can see through it. It's fiber optic, and you have a video screen, and you can see what's going on in the large airways only, but you can't really see out into the smaller airways. What I'm trying to do is, and the hospital is very interested in getting something called electromagnetic navigation bronchoscopy, where we can use like CAT scanning and GPS to get into all the little tiny nodules that you can't see and biopsy those if we need to. So that's something that the hospital is interested in getting and may end up coming online the next year or so. and that's mainly for lung cancer. So people that get bronchoscopy, usually they're here in the hospital for about 3 or 4 hours, and then they're discharged and they get to go home. And it's not so bad, you know, it's not so bad. We do different things when a scope is put down into the lungs, when people have bronchoscopies. So one thing, BAL is bronchoalveolar lavage. It just means putting fluid down the lungs and sucking it back up through the scope and sending it off to the lab to see what grows out of there. And that can be very valuable. Endobronchial biopsy is just taking forceps and going down through the scope and then getting pieces of tissue from the big airways. And people, you know, when you do that, when you do lung biopsies, the large airways, there's not much bleeding with that typically, so it's not a problem. There's something called transbronchial biopsy where you go farther out where you can't see, and you get those alveoli, those balloon tissue, and you can get bleeding with that, and you can puncture the lung probably about maybe 3% of the time. And if that happens, patients need to stay in the hospital and get a chest tube put in and have their lungs reinflated. Doesn't happen very often, but can happen. Hopefully you guys won't traverse that, but if we need to get lung tissue, we would talk about that. There's something called a Wang needle biopsy where we have a catheter that goes through the scope and we put out this needle and it goes into swollen lymph glands, and we pull back tissue plugs and send it off to the lab to see what's going on. We can do that. And then this electromagnetic navigation bronchoscopy that hopefully we'll be getting the next 6 to 12 months or so will allow us to get into very small nodules, lumps in the lung, and biopsy those. So COPD is from smoking most of the time. Like I said, once people stop smoking, the lung damage stops. You're not going to recover much lung function, but you're not going to get any worse. So lung function just goes down and down and down while people smoke, and then it stops once the smoking stops. There are newer medicines for COPD. There's a lot of money in it for the drug companies. These newer medicines, they work, but they're expensive and they have side effects. All medicines have side effects, and you have to pick what you think is worthwhile to you or not, and it depends on how much money you have and what insurance you have and your situation. Yes, ma'am.
Could you have COPD and not even smoke?
There are people that have COPD that have not, different types of exposures. I mean, a lot of people talk about secondhand smoke, and that's true, but you have to have a lot of secondhand smoke exposure to get COPD. I mean, it's got to be unbelievable. Airline stewardesses, you know, in the 60s and 70s potentially, you know, people in a bar that really, really spent tons of time in smoky bars.
I just want to say that there is another, it's generic.
Yeah, so alpha antitrypsinase deficiency is a really tough thing, and it's not common. It's very uncommon, and if we have a 35 or 40-year-old who comes in with COPD, we're doing this genetic testing, which is very accurate, that measures how much enzyme they have or don't have, but it's more than uncommon. There are very good therapies for that. There's inhaled therapies and there's IV therapies. The main treatment for that is to never smoke. Because people who have this alpha antitrypsinase deficiency, if they smoke, their lungs just dissolve. So, yeah. Yes, ma'am.
What does COPD stand for again? Pulmonary disease?
I have no idea. It's chronic obstructive pulmonary disease. COPD. Okay, so we use steroids. We use steroids to treat different lung diseases, and the steroids work well for the diseases that they work for. I mean, if you have the right disease and we give you steroids, prednisone or Solumedrol, it's going to work. But there's so many side effects from prednisone. There's so many side effects. You guys know, weight gain, hypertension, diabetes, terrible mood swings, osteoporosis, blah, blah. I mean, insomnia, just a ton of different things that happen. So it's a double-edged sword. It's a miracle, and then it's something you need to get off of as fast as you can. So we fight that battle in clinic, where we're trying to get people off of steroids. So Dr. Calson's the allergist who's been here for the past 35 years, and he's in the same situation where sometimes he has to put people on prednisone, and then he has to work really hard to try to get them off of it, because it's also nobody likes to feel fatigued and sick when they start to taper off of the prednisone. So asthma is much more steroid responsive than COPD is. Asthma is much more steroid responsive than COPD. So then that's good for people with asthma, and for people with COPD it's a lot tougher because they get steroids, but they may or may not be steroid responsive. People with farmer's lung, they really, really respond to steroids. But the main thing with farmer's lung is they need to avoid whatever's causing their lung inflammation. And then there's other steroid responsive conditions, but they're others, but they're uncommon. Bronchodilators are medicines that are inhaled that open up the breathing tubes, and many of you have used those medicines and know about those medicines. Albuterol and Provenol and all these different types of things. They open up the breathing tubes. They can increase the heart rate. They can make people jittery. There's more expensive forms of bronchodilators that are just more expensive but have less side effects. I wish they were cheap. I wish they were less expensive. I mean, there's a great one, but it's just very expensive. But it doesn't cause the jitteriness. There are short-acting or long-acting medicines that open up the breathing tubes, and they have various side effects. And then the bronchodilators help for asthma and COPD, and they can be very, very helpful. There's different types of bronchodilators. There's also there's anticholinergic bronchodilators that have a different mechanism for opening up the airway. So there's different types of bronchodilators. Antibiotics, like I said, they're for pulmonary patients. I'm not advocating that everybody be put on antibiotics or inappropriate use of that, but we use them. We don't withhold them to wait to see if people are going to get better. If people are not getting better, then they may end up getting bronchoscopy to see what the problem is, why they're having recurrent infections, and why they're not responding to standard antibiotics. But we use those antibiotics, and then if they're not working, we try to find out why. Sometimes people have fungal infections. They have other type of breathing infections, lung infections that we need to know about and treat more effectively. Oxygen is a wonderful thing if you need it. People use it at rest. They use it with exercise. They use it at night. I leave it up to the patients. It's up to them. Use it if you need it, and it's available as long as you meet the criteria for it. I think in the community, when you don't have a pulmonologist around, I think sometimes the primary care providers are sort of tricked into prescribing for oxygen therapy for people that don't need it. And it's a very, very expensive therapy. The cost to society is quite a bit. Very expensive therapy for Medicare. So I don't give oxygen to people that don't meet the criteria for it because they don't need it. So I'm very, very careful about that because it's expensive and people don't benefit from something that they don't need.
What is the criteria there?
It's desaturating to less than 88% with exertion or at rest or at night. So it's pretty generous criteria. And there's also a blood gas criteria. We have to have a certain, if you do an arterial blood gas, you have to a number that the oxygen level needs to be below that. Immunotherapy, that's where all the development is. There's a lot of study on genetic therapy and also on inflammatory cascade, how we get all this inflammation in our different tissues, but especially for us in the lungs. So there's now immunotherapy for asthma, like a pill that you can take every day that markedly decreases inflammation. That's not a steroid. And that, unfortunately, it only works in a subset of patients. There's also a shot for people that have asthma that's once a month. That's a miracle. It's a miracle. And it works for many people that need it who have severe asthma. There's immunotherapy for cystic fibrosis. And I think all the development in the next 20 years or so is going to be will be weighted towards various immunotherapies. So that's it's such a great thing. New medicines for us to get better. It's a miracle. I don't know how these scientists are so smart, but they are. Pulmonary function testing. We have a PFT lab run by the respiratory therapists here. They're very professional about it. They have patients blow into a tube, and it moves a piston, and it generates a waveform as a person breathes in and out. It's a signal, and it shows how much lung function people have. And the good thing about it is there's no radiation. It's just a tracing of how much breathing effort a person has and how much lung function they have. And it's reproducible. And you can do it every 6 months or every year or every 3 months, however often you need to do it to track how somebody's lung function is, how their breathing is, without doing x-rays or any kind of complicated tests. Patients don't like, I mean, patients really don't like it because nobody likes respiratory therapists sort of screaming in your ear, breathe in, breathe out, breathe in, breathe out. But if that's the worst part of your day, then it's not such a bad day. But so we have that here. Sleep apnea is lack of breathing during sleep. Like I said, it's about 1/3 of the population. The older you get, the floppier your throat gets. If you gain weight, if a person's postmenopause, woman's postmenopause, the throat gets floppier. When you're awake, the throat stays open. When a person goes to sleep, the throat can shut. And then people typically have to wake up every minute or 2 minutes to pop the airway open. And the next day, they don't feel good. Or the spouse is saying that they stop breathing or snore loudly or wake up gasping and choking. That's sleep apnea. And it markedly increases the risk for heart attacks and strokes, very much so, pretty much as smoking does. And it causes people to feel bad the next day. Daytime sleepiness, drowsiness, driving, personality changes. Very carefully. And so the treatment is, well, one way to diagnose it is to do these, we've got these home sleep studies now, and a company will send you a box to your house, and you just wear the box, and then it automatically downloads the information to the company, then you send the box back. They give you a mailer. It's kind of like Amazon. If you don't like it, you return it in the box, and that's it. They come pick it up. So it's real easy to do. And I read the studies online. So you do it at home, and I read it online. And then you come back into the clinic, and then I talk to you about it. The treatment is something, the treatment's right there. It's CPAP. And if you ask people about CPAP, half the people will tell you it's a miracle. They're like, oh, I felt terrible. Then I got this breathing machine at night, and I wear this ugly thing on my nose at night, and it works, and I sleep great, and I feel great, and my life has changed. So that's half the people. The other half of the people are like, this is the worst thing that's ever happened to me. I can't wear it. It makes me anxious. The respiratory therapist didn't help me. Nobody cares about me. There's condensation in the tube, all kinds of problems. I mean, it's a nuisance, and it takes months. It takes months to get used to it for a lot of people. For some people that are lucky, it can just take a few days, but most people it takes months. And the issue is that to find an interface that fits and is not so bothersome. And then sometimes people need an interface that doesn't just cover the nose, but also covers the mouth because they mouth breathe. And then you got to get a seal that fits, and it's a pain, and it's annoying. But if you get it down, if you have a severe breathing problem, sleep, and you can get it down, get it right, it can really make a difference. But it's not easy, and it requires a lot of patience. Ma'am.
Is there a cure for it, or does that thing just keep you from dropping dead in the middle of the night?
Well, the cure is to get younger. So if you can get like 20 years younger, you're set, and you won't have it anymore. Yeah. Well, some people don't have it. The best kind of sleep apnea is no sleep apnea. So if we do a sleep study and you don't have sleep apnea, you don't need a breathing machine. So there's been a lot of, I used to do a lot. I used to be a sleep researcher, and my whole young career was sleep medicine and trying to get it standardized. And the reason why I got out of sleep medicine is because you go in, you spend $2,000 for a sleep study in a lab. There's no sleep apnea, and then the doctor or whatever still prescribes CPAP. I was like, this is ridiculous. Why are we doing all this testing? Why are we doing whatever? And the patient still gets CPAP. They don't need it. So I stopped doing. I said, this is stupid. I don't do it. I'm not going to do it anymore. And I stopped. And I just said, I just want to be a regular lung doctor, and I want to do critical care. And that's what happened. Now, because I'm in Ukiah and you all need the service, I'm doing this type of testing, this home testing, because it's non-invasive, it's cheaper, and if you need a breathing machine, then it meets the Medicare criteria, you can get a breathing machine. But there's so many people, part of the reason that people can't use these breathing machines is that some of the people don't need them. And so I would never, ever, 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 ever put somebody on a breathing machine unless they really need it. If it's mild, there's other treatments. So other treatments, if it's milder, would be to get a retainer that advances the jaw forward, to get jaw surgery. There's different types of jaw surgery. It's not very effective. But there's, if it's milder, that's an option. Weight loss is another option, those type of things. But mild sleep apnea is mild sleep apnea, so you have to put it into context. If somebody stops breathing 45 times a minute, it's severe sleep apnea. It's going to really increase their risk for heart attacks and strokes. Most of the sleep studies I'm getting, people have severe sleep apnea. You're just recognizing the obvious and treating it. And the machines now have microprocessors in them so that they auto-adjust the pressure, so that you don't set a pressure, you set a pressure range so that patients get the lowest possible pressure over the course of the night. The pressure just kind of modulates. It makes it much easier to use. So the machines continue to get better as microprocessors get smaller and technology gets better. So, I mean, that's one thing that's good about the whole field. But, yep, yes, ma'am.
This is why I'm here, but, so if someone snores really loud and stops breathing now and then, they may not have sleep apnea?
Well, most of the folks that come in that have witnessed apnea, most apnea is not perceived. So what will happen is people will sleep, their airways will shut, and they'll wake up every minute for like a half a second or a second, and it won't be perceived. So recurrent lack of breathing events, recurrent short awakenings not perceived. When people come in with witnessed apnea where they wake up gasping and choking, they don't always have severe sleep apnea, but they oftentimes do. They oftentimes do. So I do sleep studies where they're negative, and I'm always happy when that's the case, because then you don't have to worry about it. But yeah. Okay, there's other things. People have other sleep problems. They have restless leg syndrome. They have narcolepsy, which is uncommon, infrequent. Insomnia is a terrible problem that increases as people get older. I don't really do any of that anymore. I don't want to do that unless nobody else will do that for you. It's not really that's not my thing anymore. But, if somebody's desperate and there's no other doctors that'll do it, I will try to help the best I can. Narcolepsy is unusual, uncommon, usually detected in people that are younger. And that's a problem. Narcolepsy is where people are just falling asleep all the time. They don't have a breathing problem at night, and they're sleeping adequately at night, where there's something wrong with the brain and they can't stay awake. You've seen things about narcolepsy. A lot of people make fun of narcolepsy. It's like people that have the drop attacks. It's called cataplexy. Like they get startled and they drop. That's cataplexy. Critical care. So the ICU here, it's a real ICU, intensive care unit here. They have intermittently very sick patients here, but only within the scope of what Ukiah can handle. If they can't handle it, they move the patients out to a bigger hospital. They don't keep patients here that they can't handle, which is is what you want. You've got to have that. So Ukiah Valley Medical Center wants to keep patients here where it's, when it's safe to do so, but if it's not safe for you or your family member, they'll want to move them to a bigger hospital where they can have additional services that might not be present here. The care is very, very good here. The nurses are very good here. The respiratory therapists are good. The radiologists are fantastic. Like I said, all these other doctors that are here are very, very good. The intensive care unit is a very important place. It really, really is. It's a life or death place oftentimes. And you don't end up in the ICU in most places unless you're critically ill. And the job there is to do everything possible to get people through their critical illnesses. So I'm here to help augment that. And Ukiah Valley Medical Center is building a new intensive care unit that'll open in 2016. And it's a big deal. It really is. So we see all kinds of things in the ICU. We see septic shock. Septic shock is shock from infection, overwhelming infection. We see breathing failure. Patients need to be on mechanical ventilators. Heart stoppage is cardiac arrest. Heart attacks, GI bleeds, is bleeding through the stomach or the colon. The new ICU is coming here. I can't wait. The trauma program is going to expand in Ukiah, so more patients that are injured traumatically, motor vehicle accidents, falls, other types of injuries can stay in Ukiah if they want to stay. We see strokes and heart attacks and shock, and I would expect that those services are going to expand. There'll be a new cath lab here within a year or 2 years. The cath lab is where they would squirt dye into the coronary arteries to see if there's blockages and to put stents in there and the whole 9 yards. So that's all coming to Ukiah, and that means that you can stay with your family members in Ukiah versus going to a different city. We're here for you. You know, I mean, the staff that's here supporting tonight, the admin staff and the doctors, the nurses, the respiratory therapists, all the support people, all the other support people, we're here for you. I mean, truly, there's no other reason. And every time you speak with the people that work here, that's all they care about. They just care about you. I mean, this is a special place. I don't know. I'm thinking it's the Adventist philosophy. That's what I'm thinking, but I'm not sure exactly what it is, or maybe it's just everybody is in it together because it's a smaller town, but everybody really cares here. It's just a special place, truly, truly. So how to best serve you is to keep it in Ukiah if we can, if it's safe for you, at your preference, or not. You know, if you want to go down to UCSF and have the residents take care of you there and get all kinds of tests and all that kind of stuff, we want you to be happy, so we'll definitely transfer you down there and such. Expertise, we have pretty great expertise here, and we're going to be getting a lot more over the next couple years. The technology will continue to build here. The personal touch is everything. Technology without the personal touch is meaningless, truly. And just the caring philosophy is what it's all about here. So, you know, it's an honor to be a part of it, and it's an honor to speak with you tonight. So thank you very much, and now we got time for questions, a lot of time. Yes, ma'am.
Can you talk again briefly about pulmonary fibrosis and the treatment thereof, if there is any, or if you find that it progresses to a certain point and then doesn't.
Okay, so the question is about pulmonary fibrosis, and unfortunately at this point in time there is no effective treatment for pulmonary fibrosis except for lung transplant. So it's a terrible problem for pulmonologists. We have no treatment that's effective. Everything has been proven to be ineffective. Steroids are not helpful. They actually increase complications in the death rate, and all the other therapies have not been shown to be effective except for lung transplant. And lung transplant is pretty extreme. So we're in a real quandary right now with pulmonary fibrosis.
Okay, but does it reach a certain point where it doesn't get any worse?
Yeah, I mean, it's supportive care. So you would hope that if somebody has pulmonary fibrosis that we do everything possible to support them and that it does not progress.
Thank you.
Yes, sir.
My wife has had asthma since the 50s, and we were in LA, and when we down there, they just give us a adrenaline shot.
Yeah.
Heart rate.
Yeah.
Then we moved up here, and she went for about 20 years just getting away from the air down there, I guess.
Yeah.
But then in the 70s, she started coming down there again, and they did the Austin and Theodore and Albumin.
Yep.
And then of course, you get ulcers and you have to take Tagamet and all that stuff.
Right.
Well, that wound up totally disabled. Then the doctor in San Jose found that she had infection around her.
Mm-hmm.
It gave her tail
Yep.
and asthma course.
Yep.
That was the best thing that ever happened. She was all the other stuff was thrown away, and she was for 10 years really great. Now you can't get that tail or any kind of bronchial antibodies, and she's not able to get any that. She needs to have there. She's slowly getting, but she can just barely walk in her room. She just, and it's been the last 4 or 5 years without getting that type of antibiotic that can actually help bronchial. What I was told by the doctor down there, he said, well, you'll need some kind of antibiotic for life, because that doesn't actually go away. An infection or bronchial. I don't know.
It sounds, you know, what we're talking about is just the lack of response to therapy for asthma, if it is asthma or something else. I don't know if it's purely asthma or something else. It sounds like it's more complicated than just asthma. But, you know, it just depends on all the specifics. So I don't know what to say. I don't know how to answer you. It's, you know, these things can be simple or they can be complicated, and I don't know. It sounds a little complicated to me. Yeah. I don't, it's hard to answer. It's hard to say much.
Make
Yeah. Well, I mean, that's up to you. If you, I mean, if you have your doc, if you're going to come see me, what would be really helpful would be to, you know, let me know which doctor it is down there, like at the, you know, and let's get your records before you come to see me, so I have them. I have your records from the other lung doctor before you come to see me.
Right down there, I don't know, he died or something. He's gone.
Which guy?
A regular bandage when you crack down.
Which doctor was it down there?
That was Saul, like
Okay.
King Saul.
Yeah. Well, okay.
He's been,
Okay.
that was in the 80s.
Okay.
And then his office went down, but then we were able to get the tail and that stuff, so we just kept doing
Okay.
it until we was not able to get it.
Okay. Well, come on. If you need me, come see me, and I'm there. Okay. Yes, sir.
I once heard that when you stop smoking, your lungs would regenerate to their original condition over another year.
They don't.
It's not true.
So the question is, do the lungs regenerate when people stop smoking? And they don't. They don't regenerate. They don't regenerate. Ma'am.
In order for Medicare to pay for coming to the clinic, would you have to have your primary physician do a referral?
Depends on your insurance. I don't know. Yeah. It's usually most primary care doctors want to make you happy. I mean, if you have breathing problems, they'll send you. I mean, it depends. Who's your primary, unless it's a secret?
Better not say.
Okay, don't say.
Get in touch.
Okay. All right. Yes, ma'am.
Do you have an opinion about the new tech implant that goes in the chest and stimulates the relaxation of the jaw diaphragm?
Yeah. You know, I mean, it would be great if it works. I mean, the real issue has been that it erodes through the soft tissue. The electrodes erode through the soft tissue and then cause problems. I had a friend. One of my proudest times was when I finished my training, my payback with the Army. I got a job at Mayo in Rochester to be the sleep guy there, and the sleep guy that was already there was wanting to do that study with Medtronic on their pacer for the soft tissue. And I laughed at him. I mean, it was mean. It was on an interview. I still got the job, but he was trying to get me to do that research study with Medtronic. I'm like, are you serious? We're going to put, you know, we're going to implant electrodes into people's pharynxes, and it's going to, you know, we're going to do that. Well, I guess we're doing it. I mean, we spend a lot of money on all kinds of things, so we're doing it. I mean, we put in, you know, defibrillators, and we put in all kinds of things. So, yeah, I mean. It's it could work. I mean, it could work. I guess I shouldn't have laughed at him, but it's made by a different company. Medtronic's bailed out on it because they had all the problem with the electrodes, you know, eroding, and I think it's still an issue now to some degree. But what they do is they pace it. They only turn it on at night when you're sleeping, and it paces with the diaphragm, and I think it can work. I think it can work, and it's all the technical issues with it that are going to be the bugaboo. And then, you know, I always wonder about America. You know, I mean, I just wonder about us because, you know, people are getting older and they get, you know, they're really like morbidly obese, and then we're putting pacemakers in their upper airway and stuff. And I mean, it's okay, but I mean, I'm like, well, maybe people should stop eating. You know, we should stop serving people Big Macs and sodas and all that kind of stuff, and they don't have to have pacemakers in their upper airway. But you know, that's a bad attitude, but that's, you know, I don't know. That's what I think. And if you come to see me, that's what I'm thinking in the back of my mind when you come to see me.
No weight restriction before they do the implant? I know that they were doing it with people that couldn't use the CPAP machine.
Yeah, no, it's not. I mean, if they're doing a clinical trial and anybody wants to be referred to the clinical trial, if they're doing it, they're probably doing it at UCSF or Stanford. I think I heard somebody's doing it down there. I mean, there's no reason not to give it a try as long as you understand what the side effects and the complications might be and you're up for it. I personally wouldn't do it unless I was pretty severe. I wouldn't do it, but that's up to you guys. I mean, I would find out about this. I mean, I used to be in the area. I could find out all the details if somebody's interested in being referred down there. And yeah. Yes, ma'am.
Can you speak a little bit as to whether or not diet has an influence, beyond obesity, that diet has an influence on pulmonary function?
A lot of people, I mean, diet never hurts. I mean, diet is positive. It changes your life. It's the most important thing. We're made up of what we eat. There's no question about it. People, my wife's a dietitian. You know, I mean, people focus on what they eat. It's a way to control things. I don't poo-poo it. You should do whatever feels right for you. Is it going to make all these underlying pulmonary diseases go away and stuff? You know, who knows? Who knows? I don't know. But I mean, I don't poo-poo it at all. And it's not, you know, I mean, the things you can do that are common sense make sense. I mean, everybody's got a theory. Everybody wants to be in control. And one of the ways that we control our environment is what we eat. So sometimes people fasten, you know, they hone in on that as a way of controlling things. I don't say that's wrong, but you know, there's a lot of other issues that are also occurring at the same time. There you go. Yes, sir.
For those of us who smoked, you know, 20 years ago, quit, you know, would you be recommending the lung CAT scan?
How many years did you smoke?
Probably for 20.
How many packs per day? Well, I mean, you could. They say 15 years, but you could talk. I mean, you could. You know, I would personally, if I.
15 years of smoking?
Or you haven't smoked for 15 years. Yeah. Well, I mean, it's up to you. That's not recommended by the criteria. Personally, if it was me, I'd probably get a screening CAT scan. I'd find a cheap CT scanner with, you know, if you could find it, you can get a CAT scanner for $250. I mean, seriously, and I mean, that's a lot of money for some people. For others, it's you know, it depends. But a screening CAT scan, for me, I would do it, but it's up to you. It doesn't meet the official criteria, though.
So probably Medicare's not going to pay for it. Then.
It depends. It depends on what if there's other issues, and it just depends. And then there's a lung cancer screening program. They're going to start here directly marketing to the patients and their primary care providers for screening, but yeah. So, yeah. Yes, ma'am.
I wanted to ask you about the clinic, and you have to have an appointment, and you have to have a referral.
You have to have a referral.
From the doctor.
Well, I mean, most of the time, yeah. I mean, you have to have an appointment. You know, we'll make an appointment so we can get your records, and yeah. So usually you make an appointment, and then we're right across the street, the Ukiah Valley Primary Care. Make an appointment, and I mean, we don't want to waste your time. So you need, you know, come in if you have a breathing issue. Don't waste your time and your money coming in there if you don't have something that I can help. You know, you think I can help with. Usually, it's good to have the referring doctor refer you. Talk to him and say, this is why I want to see him. And then that way I can send the notes back to the referring doctor. Most of the time, that's how it's done. I mean, if you wanted a special you know, circumstance, you just wanted to refer yourself, you probably could. Most people want to be referred. Yep.
I think that's a really important question for a good majority of our community because of age, most people's primary medical care is Medicare. And you know, my question, simply is, are you considered a specialist where Medicare will not pay for it unless you have a referral?
Yeah, I'm definitely a specialist. You know, Medicare is blocking a lot of things to cover to decrease cost, and it's becoming more and more of an issue. It has been an issue, and it's becoming more of an issue. Yes, ma'am.
How much is the appointment? I mean, how much is the visit if you don't have any kind of insurance?
It's a standard cost that that for any doctor or that in the clinic, we all have the same cost that the patient pays, and it depends on how much time, you know, how much time you're seen for and all that. If you tell them that you're self-pay and you don't have insurance or whatever, we charge you less. People that have if you have Medi-Cal or Covered California, then it's usually not an issue. I mean, most people are not paying out of pocket, hopefully. If you are, I have a few younger patients that are paying out of pocket, and what I do is, I'm not supposed to say, but I don't charge them as much because they're paying out of pocket and they don't have any money. Yeah, I know. That's discriminating against people that don't have any money. Yeah, or insurance.
How are you different from Dr. House?
I'm not as smart as he is. And so Dr. Kalsten is an allergist. He's been here for 35 years, and he is a very, very good doctor. And my office is 2 doors down from him, and we discuss all the cases. We're always going back and forth with the cases. So, but he's more focused on asthma, and I'm more focused on the other type of lung issues. Yeah. Yes, sir.
So, how do you want to go about getting the I would be recommended by my primary.
Yeah,
care.
just, you don't have to see, I mean, if you just want the sleep study, you don't want to see me, just tell your doctor that you don't want to see Loeb, you just want the home sleep study, and then they can call us. We have Nick's coming up with order sheets for this, so you can decide, or your primary care doctor can decide whether you just want a sleep study or you want a sleep study in conjunction with seeing me. And then if it is positive and you need to see me, then you can see me. So that's one way to try to limit the cost and all that.
Well, who would interpret the sleep study?
I would. So I just, I look at it, so again, you bring this thing home, you wear it, the signal is transmitted to a central place, and then I look at it on the computer. It's magic. So I can look at it on any computer. It's all web-based. It's amazing. It's amazing. I mean, I'm you know, it's like, why didn't, yeah.
So when he come to see you, but you get the results of the web, and then you feed back to the primary
Yeah,
care doctor?
right, and they can discuss it with you, and what I say is what the results are, and then they can discuss it with you, and if you want to see me, I'm there to be, you know, I'm there.